Just let me know when the screen sharing starts. Can you guys see the screen now?
Yes.
All right, okay,
Yes.
perfect. Okay, so let's begin with today's discussion. Today I'll be explaining you guys cranial nerves. So let's first discuss oculomotor nerve. We already know all of the cranial nerves. I guess everyone has studied them. Uh, So today we'll be discussing about oculomotor nerve. Specifically, I'll be starting with that. It's third cranial nerve, as we all know, and it's primarily responsible for controlling most of the movement of eyeball and elevating the eyelid, and also regulating the size of pupil and also shape of the lens as well. Okay, let me quickly show you guys how this looks like. All right. So this is exactly where this nerve functions. You can clearly see in this picture. Can you guys see the Chrome that I have just opened?
Mm-hmm.
Yeah, right.
Yes.
So the primary function of this nerve is to carry the both motor and parasympathetic fibers, and that's why it is also called as a mixed nerve, and it plays a central role in also maintaining proper alignment of eyes and coordinated by uh, binocular vision, and it also helps us in focusing. I want someone to read this. Please, can someone read this? Yeah, go ahead.
Anatomical overview. The oculomotor nerve originates from the midbrain at the level of the superior colliculus. It arises from two distinct nuclei, the oculomotor nucleus, somatic motor, and the indinger westphal nucleus, parasympathetic. The nerve emerges from the intrapendicular fossa and travels between the posterior cerebral artery and superior cerebral artery. It then runs along the lateral wall of the cavernous sinus and
Yes,
enters the orbit via the superior orbital fissure. Inside the orbit, it divides into superior and inferior divisions.
perfect. So the ocular motor nerve, you can see this in this image, in this detailed image. I'll just show you the image quickly. This is cavernous sinus, and these are your mammillary bodies, and this is suborbital feature. You guys can clearly see that the cranial nerve emerges from subcavernous region, and it actually originates from the midbrain, uh, so that you guys can know. And it has two important nuclei, the oculomotor nucleus, which provides somatic motor fibers, and then there is aiding westphal nucleus as well. It is somewhere here. Uh, you guys can see the cursor right here. This is it, and this is also called a ciliary ganglion, and these help in uh, these are for the superior oblique muscles, uh, superior cerebral fissures. Can someone else read this for me?
I can read.
All right, go ahead.
Somatic motor, general somatic efferent supplies voluntary skeletal muscles of the eye and is responsible for most eye movements and eyelid elevation. Parasympathetic, general visceral efferent controls involuntary functions such as constriction of the pupil and accommodation for near vision. Clinical importance, lesions produce both motor and autonomic deficits, helping in localization.
Perfect. So let's talk about the functional component of this nerve. Uh, so the the oculomotor nerve has two main functions and two main component. The first one is somatic motor uh, component, and it supplies to the extraocular muscles, and it is very responsible for in for voluntary eye movements, specifically moving your eyes and also elevation of the eyelid. And the second is parasympathetic component, and it controls the involuntary movements of the eye, that is accommodation of eye. Now, what does accommodation mean? This means that our eyes are able to adapt according to the brightness, and this is because of the dilation and uh, constriction of our pupil. So this is the parasympathetic function. Try and remember this thing. This is a parasympathetic function of our oculomotor nerve. I want someone to read this.
I can
Can
read.
someone? Yeah, go ahead.
Medial rectus, adduction of the eye. Superior rectus, elevation of the interrosens. Inferior rectus, depression of the extorsens. Inferior oblique, elevation and adducted position at the extorosen. Levator palpebria subrosis, elevation of the upper eyelid. These muscles together enable coordinated eye movement and visual tracking.
All right. Okay. So you can clearly see that this is your eye, and these are the muscles that are all innervated using the oculomotor nerve. So you can respectively see what's the function of each muscle. So median rectus you can see on the right side of the screen, and this is for the adduction of the eye. That means moving the eye close to the nose. Uh, yeah, no, I think it is for moving eye away from the away from the nose. Superior rectus is present right here. This is for the elevation, and inferior rectus is for the extrusion. Uh, extrusion means moving outside and also uh, moving outside and down. And also it is responsible for depression. Depression means moving eye down. And inferior oblique, you can see here, it's for the adduction. Adduction, that means towards the nose. Elevation in adduction, and you can see that there is levator palpebrae superiors. This just means superior oblique muscle, and this is for the movement of eyelid. And these muscles together enable coordinated eye movement and visual tracking. Quite easy, quite obvious. You can see that there is a test for eyes as well. You can see that here doctor is performing test for the oculomotor nerve. We usually perform this to check if the eye is able to move properly. Yeah, this is how the test looks like. I'm sure you might have seen this in clinical skills. I think so. And if not, you will be seeing this in a physical diagnosis classes in the next semester, hopefully. Can someone read the parasympathetic pathway? Hello.
I can.
All right. Okay.
A parasympathetic fibers originate in the Edinger westful nucleus. Preganglionic fibers travel with the oculomotor nerve to the cellular ganglion. They synapse in the cellular ganglion. Postganglion fibers travel via short ciliary nerves. They innervate the sphincter pupillae and ciliary muscle, controlling pupil size and lens shape.
All right. Okay. So the parasympathetic fibers originate in the Edinger-Westphal's nucleus in the midbrain. So you guys can see the midbrain right here, and yeah, this is your midbrain. It's a transverse section of your midbrain. These preganglionic fibers travel along with the oculomotor nerve, and they synapse in the ciliary ganglion region within the orbit. Uh, so right here, and from there, the postganglionic fibers travel via short ciliary nerves and innervate to the sphincter papillae and ciliary muscles of the eye. And this is the you can see that this is the effector pathway, efferent pathway right here. Uh, and this is basically the parasympathetic pathway of the oculomotor nerve. I want someone to read this. Someone who hasn't read yet.
Can I read?
All right. Okay.
Okay, we have pupillary light reflex. Light entering the eye stimulates the retina. Signals travel via the optic nerve to the preauricular nucleus. Interneurons connect the bilateral of inner Westphal nuclei. Parasympathetic fibers travel via central cranial nerve 3 to the constrict pupils. This procedure produces both direct and consensual light reflexes.
Yeah.
Consensual.
Consensual light reflexes. So let me tell you guys, there are two ways of shining light into the eye. First one is when you put light directly into the eye, and the second one is when you put light on the cornea, on the iris, but not directly. It's called as consensual. So basically, we put light from the side. and usually the pupillary light reflex begins when the light enters into the eye and then stimulates the retina. The signal is transmitted via optic nerve. You guys already know what the optic nerve is. To the There is a paratec paratectal nucleus that is present in the midbrain, and this is where Edinger-Westphal that we just discussed right here. This Edinger-Westphal nucleus and in the midbrain, these two are connected, and this helps in constructing both pupils together. But And this is usually direct response. It is usually against the direct response from the consensual light from the opposite eye. So clinically, this reflex helps us to assess both afferent limb, which is optic nerve. You already know afferent. I just had the image right here. Yeah, I think we lost the image, but yeah, you can see afferent, that is optic nerve, and the efferent nerve, which is oculomotor nerve. So we can test both using this response. So this is very important thing again. Try and remember this thing. So if there is a lesion, usually you don't get to see this reflex. Can someone? I think we will skip the accommodation reflex because you already guys know that near objects and far objects can be seen using, there's a lens in your eye, and lens when the lens bulges, your eye tends to focus on the closer images, and when the lens is stretched, it usually focuses things from the far away distance. This is accommodation. So I think we should skip this. I want someone to read about the palsy. Now let's learn about the palsy. Someone else who hasn't read yet, please.
I can read.
Okay.
Oculomotor nerve palsy. Ptosis occurs due to paralysis of levator palpebra superioris. Eye deviates down and out due to unopposed action of lateral rectus and superior oblique. Diplopia occurs due to misalignment of eyes. Patient cannot move eye upward, downward, or medially.
All right, okay. So let's talk about the oculomotor nerve palsy because this is our first cranial nerve clinical case that we will be talking. Let me show you guys the palsy. Palsy. Just a minute. Right, okay. So now you guys would be able to see and kind of try and correlate this. You guys can see that the person is looking, not really trying to look in the sideways, but you can see that there is ptosis. Can you guys see the image clearly? Hello.
Yes.
Yeah, so there is ptosis, there is also mydriasis. This means that there is decreased tone in the pupil muscles, and then there is down and out movement of the eye. So you can see that this is normal eye. This one right here, this is the normal eye, but you can see that this eye is a little bit abnormal. So oculomotor nerve palsy is very it's a very characteristic feature that is observed, and there is a down and out. Try and remember this thing, down and out, and there is also ptosis. And also diplopia occurs because obviously one eye is looking straight and the other eye is looking on the sideward. So patient's brain would see these as two separate objects, but rather these are just one. And that's why there is diplopia. And patient cannot move his eye upwards, downwards, and medially. So this is usually caused by the lesion of the nerve. Very important thing. I want someone to read this, please. Okay, I'll just explain it. So there is also mydriasis that we can see, and pupil does not constrict to the light. So this is why I told you that reflex of the eye, the pupil tends to increase its size from smaller to the larger when he moves to the darker environment. So this is usually impaired in this nerve, and a pupil sparing suggests that there is ischemic lesion such as diabetes, and parasympathetic fibers are superficial and affects early in the compression. Uh, Now let's talk about the causes of palsy. Now, what do you think? What could be the causes? I want someone to read this quickly. Someone else, maybe who has not read yet. Hello, can you guys hear me?
Yes, I can read. I can read.
Yeah, okay, go ahead.
Causes
I
of
can't see your
CN3.
names,
My
so that's
name.
why.
Oh, okay, it's fine. Compressive causes include posterior communicating artery aneurysm.
Aneurysm.
Aneurysm. Tumors and ankle herniation. Ischemic causes include diabetes mellitus, hypertension, microvascular infarction. Other causes include trauma, midbrain infarction, infections, and inflammation.
Okay, all right. I'll explain this to you guys. So basically, this cranial nerve palsy is, it's broadly divided into there's like compressive, then there are ischemic. There is compressive, then there is ischemic, and then there are other causes. Other causes are trauma. So maybe a patient has had a minor accident or something. It could be midbrain infraction, also infection of certain kind, and also inflammation. These are quite common. Now, ischemic causes. This just means that if the patient has diabetes or hypertension or microvascular, there is not enough infraction. So there is not enough amount of blood that is reaching to the nerve, and that's why there is ischemic lesion, and that's why this palsy usually happens. Try and remember this thing: down and out, down and out. And then there is compressive cause as well. This is because of the posterior communicating artery aneurysm. That is usually arteries develop a balloon like thing, and that's why there is incomplete blood flow. And sometimes these aneurysms might also burst, causing not enough blood supply. Also, there could be tumors that are blocking the artery, and also there could be herniation as well. So really high yield. Now let's talk about the clinical aspect of oculomotor nerve. Can someone please read this? I want someone who has not read yet. Hold on, let me check. Arpita Abhijit, are you here? Hello.
Yes, I can.
All right. Okay, go ahead.
A clinical examination, inspect for ptosis and abnormal eye position, test extraocular movement using edge patterns and accommodation, observe for
Perfect. And
diplopia,
next one.
deviation, and pupillary abnormalities.
Okay. So if a patient comes now, imagine that you guys are doctors and a patient comes to you guys, and you and if you want to try and guess what the person has, so there are some of the tests that you can perform. So first of all, what you will see is if the patient has ptosis. Second is if there is any abnormal eye position, as we talked. It could be down and out. It could not be this. There's multiple possibilities. We should also test for extraocular movements using H pattern. Now, what is this H pattern? We usually ask the patient. Now, let's imagine this is our patient. We ask the patient to follow, and now this is your physician. Okay, this is your physician. Let's write P here. Okay, so we usually ask patient to follow physician's fingers, and then we draw a H and ask patient to follow. If the patient's muscles are properly innervated and if everything is fine, patient's eyeballs movement can be tracked, and this is how the H pattern test works. And then there is also light reflex. We usually take the patient into the dark and then we shine direct light and then consensual light and then check if the pupils are able to constrict properly. And then we also observe for diplopia, deviation, and also pupillary abnormalities. These are typical signs that there is some lesion in the oculomotor nerve, that is third cranial nerve. Now, talking about the summary, you already know that the oculomotor nerve, since we just discussed 5 minutes ago that oculomotor nerve controls all of the eyelid elevation, pupil constriction, and also accommodation. And usually palsy, the classic presentation of the palsy includes ptosis, down and out eye, and then possibly also dilated pupil. So that's it from my side. Now let's try to solve questions. I want someone to read the first one. Yeah, yes, Ryan, go ahead.
Which of the following function is probably carried out by the oculomotor nerve?
Oculomotor nerve.
It's
Yeah.
B.
All right. Which one? B. Which one?
It's B. B.
Okay, yeah, correct. Next one, please. Someone else. Bayan, please.
Yes, yes. The parasympathetic fibers of the oculomotor nerve originate from which nucleus? It's B. Edinger-Westphal nucleus.
Yeah, perfect. And the last one.
I can read. Which
Yeah, okay,
muscle is
go ahead.
supplied by the oculomotor nerve? C. Lateral rectus.
Thank you so much, guys. That's it.